main thing for me is if this child has a dentist first and foremost. Any source of infection in their mouth that they have could be significant in impacting their medical care. Pick it up, lick it to make sure that there's no gross contaminants on it, and stick it back in the mouth in the right position.
So welcome. It's very exciting to see you today, Greg. And it's lovely for us to have some input from a real life dentist, because I think we're very bad about thinking about teeth in children. Would you like to introduce yourself?
So hi, I'm Greig Taylor. I'm currently a clinical lecturer and specialist in paediatric dentistry, working in Newcastle University and Newcastle-upon-Tyne Hospitals Trust.
That's brilliant. And if we were to get you to think about your top 3 bad things in children's dental health, I'm guessing that caries and infections would be really high up on your list. So what kind of things do you want to tell us about children and holes in their teeth?
Yes, so dental caries is one of the most frustrating disease entities. It's the most common condition that causes children to have to be admitted to hospital for dental extractions, but ultimately it's a preventable disease. There are certainly measures, both public health right through to chairside level of care interventions, that can prevent this disease, but it still remains one of the most frustrating things to date, particularly because the things that cause it are high sugars in our diet, lack of fluoride in terms of not applying them through toothbrushing, or not having engagement with things like community water fluoridation schemes. So yes, it's quite disappointing, I think, that in a developed country we still have children with age 8, 1 in sort of a third, have dental decay in at least visible tooth in their mouth. And the impact that it has on these children is quite significant. Any of you who have had toothache before will know the sort of consequences that are suffered by this, but also the impact of not having to attend school, potentially not having to also be able to having to not be able to take part in activities can also be quite difficult for these children.
Greg, yeah, it's so frustrating because I think it's unbelievable, but the most common reason to have a general anaesthetic is for tooth extraction out of all children's health problems. Isn't that true?
That's absolutely correct, Emma. Yes, and it's more than double those children undergoing tonsillectomy or ENT procedures. But in addition to that, as it being a preventable disease, it also costs significant amounts of funds to the NHS for hospital admissions. And again, going back to this, something that it is a preventable condition.
Do you know how many bed days that is?
Off the top of my head, I really don't. But in terms of the number of children, if my memory serves me correct, it's pushing sort of 6,000 children per annum.
That's outrageous.
It's a significant number of children across the UK.
So when you're thinking about children in the community, how many children have dental decay?
So based on our most recent child dental health survey nationally, about 1 in third by 8 years old will have an obvious dental decay, and that figure slightly increases by the time they get to age 12 and 15. So it's a significant problem that we face and see. And in some children, that might be one tooth, but in others, it might be affecting all of their baby or, sadly, adult teeth.
That's shocking. So you're saying a third of all children have holes in their teeth?
By the age of 8, yeah, around that figure.
And what sort of impact does that have on kids?
The most common impact is dental pain and associated features with that. That may present as not being able to attend school, not eating and drinking properly, having sleep loss during the night, which then impacts on their daily lives and routine. But in addition, it also may progress into dental infections and, in the worst case scenario, sepsis, requiring hospital admission and multiple antibiotic courses, if not emergency surgery.
So if you were sitting in the paediatric emergency department and a child comes in complaining of pain in their mouth or swelling around their mouth, what would you ask people to look out for? What would you ask paediatricians to look out for?
The main thing for me is if this child has a dentist first and foremost, because in the majority of cases they need to be signposted back to their primary care practitioner to go through the appropriate channels. But if they're not registered and they have evidence of recurrent pain for several days that pain relief is not relieving, or they are having to have multiple courses of antibiotics, or have visible signs of a swelling or suggestions that they are potentially septic, then these patients obviously require urgent attention, whether that be through your pediatric dental colleagues, referral to your oral maxillofacial colleagues if you don't have pediatric dentistry available, or again working alongside pediatricians who can then liaise with the appropriate members of staff at their closest hospital.
Great. So what you're saying is if it's a bit more complicated, if children have any signs of being unwell, if they've got fevers, if they've got obvious swellings, pain that's not getting better, recurrent, had a course of antibiotics and not improving, they're the ones that need to be assessed and follow through.
Yeah, you're absolutely right, Emma. These patients need to be signposted appropriately, and that will depend on whether they're effectively septic or not. But it's trying to triage those and make sure that these children don't just fall through the net and don't get care, because it will just continue to be problematic for them. And then, if there are recurrent infections, that can have an impact on their developing adult tooth or adult dentition as well. So it's not just a problem for now, particularly younger children, it's a problem for the future as well.
Yeah, and I think that's one of the things that makes it so frustrating because you said actually the treatment for this is prevention. So talk to me a little about prevention. Give me 3 top tips for preventing holes in children.
It's really simple, Emma. The only way a hole develops on a tooth is if there's sugar given to the bacteria that sits in dental plaque. So if you reduce the sugar intake and the frequency of that, it will certainly not then turn into holes in teeth. So the biggest thing for me, and 3 tips I would always advise, is to minimize and reduce any sugary snacks or drinks to meal times and to dinner times. To make sure that the second tip would be to ensure that fluoride toothpaste is used twice daily, at least, most importantly, in the evening and one other time during the day. There's often a misconception it has to be morning and evening, and sometimes that doesn't always fit into routines of adults and families. But nighttime is most important to brush because of our dry mouths overnight, and therefore sugars can cause real problems. And the third tip for me would be at best to try and attend a dental practice, which currently is particularly challenging, but that sort of recurrent emphasis on prevention and the chairside led prevention that dental professionals can provide is that kind of third area of strength that can really stop and halt this process.
Right, so let's just have a quick reminder. First of all, get a dentist. And remember, dentists are free for children.
That's correct, yes. So in the NHS, the current contract would still provide dental care for all children up to the age of 18 for free. Um, the kind of current issue, though, is trying to access that NHS dentistry. And there is a recovery plan within the NHS set out by the new government, which hopefully will start to show some signs of improvement. But certainly, if their children are not registered, then as every contact should count, it's important to make sure that that message is consistent across healthcare professionals.
Perfect. And number 2, you said brush your teeth twice a day. And that seems really obvious. But actually, we know through some work we've done that getting toothpaste and toothbrushes is actually quite expensive. And if you're struggling to heat your house and just buy food, it's an extra expense people can't afford. So there's a new program for toothbrushing in schools.
Yeah, you're correct. I think for those who are fortunate in society that can purchase fluoride toothpaste, it's great, and the message should be simple for them. But for a lot of children who are currently living in a sort of cost of living crisis, these are often the most affected children by dental caries, as it is a disease of inequality. So therefore, it's compounding the fact that not only can they not necessarily eat the healthiest of foods or access oral hygiene products, they're often then those who are in a highest situation where disease will just get even worse for these patients. So there are certainly some new initiatives that are going through supervised toothbrushing schemes that have been rolled out in areas within the northeast already, but are expanding.
Okay, and last of all, which is my absolute thing that drives me insane, in my world, children should only drink milk or water. And the number of children I see in clinic drinking fizzy drinks, and sweet snacks multiple times a day, it drives me absolutely insane.
You and me both, Emma. I think it's particularly frustrating because actually a lot of these products are extortionate in their price compared to what is cheaper in the alternative milk and water. Sadly, though, I think that a lot of these children are targeted by a lot of these companies to for these sort of fizzy drinks, etc. And sometimes just lack of education. It's easier to get a diet coke than it is to put the tap on, which is quite sad. But yeah, I sincerely hope that that is something I would like to change as well in terms of making sure that milk and water is properly struck as the main thing to drink. It's the safest thing to drink, and it's often the cheapest thing to drink.
All right, so we've talked about dental decay. We've talked about how to prevent dental decay. But there are children who have other medical conditions who really do need to see a specialist paediatric dentist. So, who are the patients you really like to be referred if a paediatrician sees them?
From a specialist input, Emma, you're absolutely correct. Those patients that are likely to become immunocompromised because of impending treatment, transplant treatment, or those who are at high risk of infective endocarditis. So your immunology, oncology, renal, cardiac patients all are absolutely key to ensure they have a specialist level input in their treatment planning because any source of infection in their mouth that they have could be significant in impacting their medical care and in some cases be even more fatal. So it's important that they are screened appropriately and checked by a specialist in paediatric dentistry.
All right, so let's break that down. That's really important. You know that I see children who are about to have bone marrow transplant, so we always get their teeth and gums checked. Because, as you say, in any child who's immunocompromised, so those having chemotherapy, those on certain drugs, primary immunodeficiency, they are more likely to get serious infections. And certainly, if they're immunosuppressed due to treatments, they may get sepsis. And as you say, an infection could be life threatening. We're also talking about children with cardiac problems and children with chronic renal disease. But one of the really big groups of children are children with diabetes. Do you have any special tips for children with diabetes?
So it's often a difficult one because of the comorbidities that unpoorly controlled diabetics are often due to, as you know, uncontrolled sugars, particularly, or having to deal with hypo attacks with things that aren't always great from a dental point of view. And there has to be a pragmatic sort of risk benefit analysis for these patients. But I think it can become really demonstrable when we see these patients in clinic who have widespread not only dental disease but periodontal infections, so gum disease. There's a huge link between type 1 and type 2 diabetes and gum disease or gum infections. So the prevention is just as imperative for these patients as those who are acutely immunocompromised.
Right, that's really interesting. I hadn't thought about that. So, in children with diabetes, they might be having hypoglycemias and having to have multiple very, very sugary drinks. And of course, they are at children with diabetes are at greater risk of infection. So is there a quick thing? Should they just like brush their teeth after having sugary drink if they need them?
So you may think that be the correct thing, but actually that makes it worse. Because if you brush your teeth straight after having something sugary, your mouth is in an even more vulnerable state. So actually, to balance the pH levels of the acidic natures that sugary foods cause, it's probably better to have something more neutralizing, like a glass of milk, a small piece of cheese, something bit of bread that will actually bring the pH level back up. If you brush straight away, the teeth are in a more vulnerable state, and actually you'll be brushing off more enamel. Yes, in small microscopic amounts, but over enough time it will continue to do that damage. So certainly that's the advice. I would be not advising patients to do that, to brush straight away after having some sugary hits.
Interesting. So after your sugary hit, you have to eat cheese, bread, or milk, neutralize the pH in your mouth, and then brush your teeth. So is gum good?
Sugar-free gum, yes. Xylitol, yes. But the gums that are, as I remember as a child, the Hubba Bubba, which is purely just sugar and has no effect other than just damaging your teeth, is not ideal. So yes, I would certainly say I would encourage children to have sugar-free gum at age appropriate. We're talking sort of 10 and above, if that makes sense, is where I would feel more comfortable to kind of encourage that.
Interesting. Okay, so we've talked about immunocompromised children, we've talked about children with diabetes. What about children with things like um, cerebral palsy and learning difficulties and autism? Because I think they're a really huge at risk group.
Yeah, you're absolutely right, Emma. I think children with special education needs, but also learning difficulties, are particularly challenging. Their routine care often is not carried out in primary dental services. They tend to be seen within the community dental services, which is often the most appropriate place for these children. I think, in particularly, those children who can't advocate for themselves or can't advocate or provide their own oral hygiene rely entirely on others. That's when it's really working with the parents to kind of make sure that you can get that toothbrushing instruction on board. It can be more challenging in some of these children, and that's where a specialist in pediatric dentistry can really come in to provide some more practical tips that are patient specific and tailored to that individual, because not everything fits for those children. There has to be some sort of nuances that would be particularly pertinent for that individual family, and that's where the skill of that specialist comes in.
In a child who, for example, is nonverbal and doesn't want to open their mouth, what's the easiest way to brush their teeth?
So it's the easiest way is really perseverance, and when I mean that, is that if you persevere long enough and you try in a sort of systematic fashion, in most cases, children generally will allow a toothbrush in there. And it might need to be built up over time with a dry toothbrush, a small tooth with a children's toothbrush. There are also toothpastes which are non foaming, so they're SLS free. They also have no flavour to them. And often we find with those children who have sensory issues, particularly the autistic group, that actually is sometimes the biggest problems. The toothpaste are too spicy or because they foam in their mouth. So currently there's only one available toothpaste called Oronurse, which is on the market, which we recommend to all of our autistic patients and indeed those children who have additional learning needs, because it tends to just be accepted much more readily by these patients.
Okay, so that's really interesting. So if you have a child with learning disabilities or autism spectrum disorder, then you think about breaking toothbrushing down to small steps, getting them used to a toothbrush, getting them used to a dry toothbrush, and using toothpaste that don't have strong taste and don't foam. And the one you recommend is Oronurse.
That's correct.
Perfect. That's really interesting. I don't know why I didn't think about that. Sounds so obvious. There's one more thing that we get presented with that I never know what to do. When children come in because they've knocked out their teeth, so they're holding a tooth, what do you do? And I'm going to break that down into milk teeth and adult teeth.
So I will break my answer down into those. If it's a baby tooth, and we're talking in children under the age of 6.5 here, six usually 6.5. If it's a baby tooth that's come out, then you in theory don't need to put it back in. You shouldn't put it back in. It's not advisable to do so. However, it might be worthwhile checking with a specialist in paediatric dentistry or even MaxFax to confirm that it is a primary tooth.
Yeah, that's so funny. I've got a really funny story. One of my friends is an orthopedic surgeon, and his daughter was about, I don't know, she was about 7. And his wife came running in going, "Oh, she's knocked out her tooth." And they rushed to the emergency department with the tooth all wrapped up, sat there for hours and hours, and he was Googling on his phone. And then he just went, a tooth is supposed to fall out at this age. And they just wasted their whole evening. So I think that's really good advice. Under 6, you said still don't worry, but you can get it checked.
Yeah, I think if it's a baby tooth and it falls out, do not worry. Indeed, give it to us. We know the tooth fairies.
All right, so adult teeth. Let's think about permanent teeth, permanent dentition. If it falls out, what do you do?
So if it falls out, the best thing to do is to put it back in as quick as possible. All of the evidence would suggest that long-term success and outcomes are improved the quicker you get it back in. And it's really as simple as push it back in. We would encourage school teachers, educators to do that as long as it's generally clean, so there's no dirt on it, rinsed under with some sort of saline in a clinical situation, and push it back in and wait for a dentist or MaxFax to come and help hold it and splint it in that position. So the kind of advice that we would often say is pick it, lick it, stick it. That's kind of the simple public health measure. Pick it up, lick it to make sure that there's no gross contaminants on it, and stick it back in the mouth in the right position.
I love that. Pick it, lick it, stick it. One last question. What happens if they knock the tooth out and it hasn't got the root or it's damaged? What do you do then? It's like a hockey match. Somebody smashed you in the face.
So yes, again, it's all dependent on age, development, how much the root's developed. But the guidance would still say that any adult tooth that's been knocked out, stick it back in, because if it hasn't fully formed, there's always a chance it will regenerate and continue to grow. Even if it's been out the mouth as a completely developed tooth and it's been a long time, it's much better to be in there and holding the bone and holding that to make life a lot easier when they're older. So I would always encourage any tooth an adult dentition knocked out to be put back in. The only thing, Emma, might be worth just considering though with the avulsion replantation is if the child is immunocompromised. So if they are undergoing
Okay.
if they're undergoing chemotherapy oncology, then that would be the only situation I wouldn't put it back in.
All right. So your one proviso is if they're immunocompromised, you don't necessarily stick the tooth straight in. You ring Greg first.
Yeah, or yeah, ring one of us for advice and discussion.
All right, Greg. Let's have your 3 top tips for healthy teeth in children.
Tip number 1: minimize sugary intakes and encourage that with all of your patients. Number 2: get them to brush their teeth. It's a simple win, as I've already talked about. And 3: encourage them to attend or go to a dentist or engage in supervised toothbrushing programs and public health measures if they're not accessed with a dentist. It's the majority of children who have dental disease. It is preventable, and it will make life a lot easier for them, for the NHS, and the wider society if we could get a hold of this problem and start to reduce its problem and its impacts.
Amazing. And 3 top tips for paediatricians referring patients. Who do you want to see?
So we want to see patients who are likely to become immunocompromised or are already immunocompromised. They're massively important for us to reduce the risk of a dental disease infection. We also want to see patients of whom you're having difficulties with if they're of special education or learning needs. we're more than happy to see those patients, and a lot of the times the families would really welcome that input. But thirdly, the patients groups that we love to see are those who are maybe routine children going for general anaesthetic procedures, or inpatients who are going for general anaesthetic procedures, who will also potentially have dental problems, and trying to minimise those by doing piggyback type procedures is something that can be of real importance to the hospital for waiting lists, but also to the patients, and having to not go through the trauma of multiple general anaesthetics when trying to do several things at once can be of much more benefit.
That's a really good tip. So, like, if you have a child who's going for a central line, think about whether they need a tooth checkup under their general anaesthetic.
Yeah, and particularly those patients who maybe have got additional learning needs and we can't do a full examination. Sometimes just being able to have a look in their mouth when they're under anaesthetic, not necessarily do treatment, but that examination can provide reassurance to the family that there is no problems, or there are no problems. Or actually, it can provide reassurance to the family, even though there is some dental issues, we need to address it, and let's make a plan appropriately to do so.
Amazing. Well, it's been really fun talking to you. And I was going to say, you know how people say, I'm really proud of running a marathon, or I'm really proud of raising loads of money. I'm really proud that I got 2 of my children to 18 with no holes in their teeth. I consider that to be one of my greatest life achievements.
I commend you on that, Emma.
This podcast is produced by Odland Education. The views, thoughts and opinions expressed in this podcast relate solely to the speaker and not necessarily to their employer, organisation, the Royal College of Paediatrics and Child Health, or any other groups or individual. You can find a wealth of information on the important work of the Royal College of Paediatrics and Child Health on rcpch.ac.uk or #ChoosePaediatrics.